Good afternoon, everyone. I can see Dr. Ketan. Dr. Ketan is here. So I welcome you also, sir, to chair the program. And you know that arrhythmia has always been a backbench kind of treatment in the education, medical education, at least up to MBBS. Even at MD level and all, we were very, few arrhythmias, and there were few people only who could taught us very good arrhythmia. So, Ulhas Pandurangi, I know him for years together. When we started this, he started this program by BARD in Hyderabad. You would remember that that program we were together. So, and I was so enthusiastic, even in those days, that I was, I went for that program, which was dedicated to electrophysiologists. But I was there, I thought whatever I learned, I learned. And second guy who is a son of a soil, Dr. Ashish Thakur, he would be speaking on something like sudden cardiac death perspective. And RD Yadave is probably traveling, so he will not be free to come to us our platform immediately. We will see that. So yeah, in the last. Yeah. So what I'll request Dr. Ulhas, as the name suggests, Ulhas, pleasure. So I have the pleasure of inviting you, sir, to speak on wide complex tachycardia. Thank you.
Ajay sir, namaste and hello everyone. It's an honor for me to be with you all. Congratulations to the Bihar chapter of Cardiology Society of India. I just was witnessing the last session, how academically strong the discussions were. I hope I carry on that inspiration during my presentation on the wide QRS tachycardia. For the benefit of the audience and the convenience with respect to the timing, I would like to talk on a wide QRS tachycardia specifically with a couple of definitions. And for the convenience purpose, let us consider a wide QRS tachycardia as that tachycardia where the ventricular rate is more than 100 beats per minute. The width of the QRS is between 110 and 120 or above. And for the convenient purpose, we'll discuss on a regular wide QRS tachycardia, and which is also monomorphic. Why there is so much of discussion on wide QRS tachycardia? Because we need to be differentiating whether the wide QRS tachycardia is truly a supraventricular tachycardia with an aberrancy, or it is the tachycardia originating from the ventricle. It's because it's so very important to differentiate, because we got to make what could be the prognosis and what should be the therapy to deal with acutely as well as during the long term. Why at all a particular tachycardia on a surface ECG becomes wide? Let's look at the mechanism. For example, in case of supraventricular tachycardia, when the impulses go down the normal conduction, both the ventricles are going to be activated near simultaneously, and hence the QRS duration is usually between 80 to 90 milliseconds. But for example, in this case, the blinking star is an ectopic origin from atrium, and then when it conducts down, if it finds a block in one of the bundle branches, for example, in this case here, a right bundle branch block, then what happens is the left ventricle gets activated and early, and the right ventricle get activated later, and that also not through the normal course of conduction. So the left ventricle getting activated first in right bundle, right ventricle gets activated later, and hence the QRS appears to be right bundle branch block. So this is the mechanism for a supraventricular tachycardia with a conduction aberrancy. How about a ventricular tachycardia? Why the tachycardia on the surface ECG appears to be wide QRS. Let us consider this example where there is an ectopy originating from within the myocardium. The blinking star here, for example, is the left ventricular myocardial origin of ventricular tachycardia. Now, this cannot get into the conduction system directly. It has to get into the conduction system through the intramyocardial course. And wherever it reaches the conduction system early, from there onwards, the impulse will get conducted along the channels of the conduction system. And then the QRS gets initiated. And hence, the duration of the biventricular activation becomes really long and the QRS becomes wide. There are several algorithms ever since the introduction of electrocardiology in the clinical practice. People went on looking at why the QRS is wide and what could be the mechanism. One of the earliest publications with respect to defining tachycardia as a ventricular tachycardia on the basis of the width of the QRS started from Sandler and Marriott in 1965. They looked at the precordial concordance as well as what are the characteristics of a QRS in V1. And thereon till now, for example, the last criteria what I showed is 2010 and even recently. So every single year there are going to be some observations, refining of the characters, etc. So to name few, which are clinically very relevant are the WELLEN'S criteria, a criteria called Kinwall criteria, Brugada criteria is very famous, Griffith criteria, Vereckei criteria, etc. I will go very, very quickly over these before we start looking at the clinical issues. One of the WELLEN'S criteria, which is so very simple, if someone does not remember these complex things, for example, AV dissociation, capture bit, etc., the WELLEN'S suggested to look at two specific leads, for example, in V1 and in V6. If the QRS appears to be kind of a right bundle branch block, WELLEN'S suggested that you look carefully at the V1. If in right bundle branch block configuration in the V1, if the QRS appears to be any one of these forms, what are those? A Q and an R, or just a monophasic R, or the left part of the V1, that's called rabbit ear, left rabbit ear taller. If these are the characteristics, WELLEN'S proved that it is most likely a ventricular tachycardia. On top of that, if the right bundle branch morphology in the V6 appears to be small r and a deeper S, he considered that tachycardia should be ventricular tachycardia unless put by otherwise. WELLEN'S another criteria with respect to only the morphology was the LBBB configuration. And during what appears to be LBBB, if you have any Q or a QS, WELLEN'S considered that this has to be ventricular tachycardia. Kinwall also came out with one of the simple and very widely practiced criterion, and that is to look at either lead V1 and V2. He suggested in case of a left bundle branch block pattern in V1, look for the initial R, and if the initial R is fat in the sense that the duration is more than 30 milliseconds, and the descending limb of the S, if it has a notch, and if the beginning of the QRS to the nadir of the S is more than 70 milliseconds, Kinwall suggested that it has to be ventricular tachycardia. Very simple and easily practiced criterion. Vereckei, a little complex, but very, very useful sometimes. He asked us to look at the AVR. And he suggested that in the AVR, if the QRS is monophasic and positive, this has to be VT. In case if it is not monophasic, but it is kind of a triphasic, and if there's an initial Q and if there's a small R, and if both of them are a little wider, for example, more than 40 milliseconds, he considered that it has to be VT. Many a times, the QRS is negative, and we believe that it's most likely a supraventricular tachycardia and aberrancy. Vereckei's criteria helps us to distinguish even in that situation. What he says is in AVR, even if the QRS is negative, do not ignore the AVR. Try to look at the notches along the descending limb of the negative QRS complex in AVR. If there are notches, it is suggestive of ventricular tachycardia. He goes one step ahead. Even when there is a negative QS complex, he asks us to look at how is the initial part of that negative QRS complex and how it is the latter part. If the initial part is more slurred and takes more time in the 40 milliseconds as compared to the latter, he proved that it has to be ventricular tachycardia. Putting all together some of the characteristics, for example, this is clearly a monophasic R. On top of that, if there's any confusion, well, you may actually look very carefully. You may actually really look deeply, for example, as if you are taking a magnifying lens. What I see here is, there's kind of a notch here, which is absent here, very, very faint notch. Well, you are confused, but take the help of another lead. Maybe that particular notch becomes more prominent. For example, here in V2 simultaneously recorded, you have a complex here, which is absent here, and the complex comes here. For every two QRS, you have one. So the ventricular rate is more, and this is typically called AV dissociation. To quickly revise the morphological criteria, if there's an RBBB morphology, look at whether the R is monophasic, whether there's a QR, etc. And if in RBBB, look at the V6 small r and a big S. In the LBBB, I was talking about in the V1, look at the initial R, slur, etc. Axis also sometimes helps. If the axis is northwest, for example, all the complexes are negative in the limb leads, it is almost always as a ventricular tachycardia, one of the very simple criterion to be used in the clinical practice. If at all you have a discordant axis, for example, the wide QRS appears to be right bundle branch block, but that is associated with the left axis deviation, or if there's a left bundle branch block morphology and that is discordant in the axis in the limb leads, for example, right axis deviation. These all suggest ventricular tachycardia. However, one should remember there are limitations of the ECG criteria. For example, idiopathic ventricular tachycardia, when the heart is structurally normal, myocardium is not diseased, even though it's a ventricular tachycardia, the conduction could be so fast in the normal heart. All these criteria may actually fail. And it is not uncommon. Most of the idiopathic ventricular tachycardia, for example, RVOT VT, left ventricular outflow tract tachycardias, even fascicular VT with the leftward axis, often they are mistreated as supraventricular tachycardia. So most of the criteria what we have used today so far, they all are pertaining to really kind of a sick hearts and ventricular tachycardia. But if you have an idiopathic ventricular tachycardia, we need to be more meticulous in analyzing those traces. With those limitations and the criteria, which are too many, if it is quite confusing to some of the beginners, my request is to consider any wide QRS tachycardia as a ventricular tachycardia, unless you are not sure. Then it is better from the point of view of safety. It is not very wise to use adenosine to make the diagnosis in a wide QRS tachycardia. For example, an antidromic tachycardia, if you use an adenosine, maybe there's a termination, all right, but adenosine is known to cause atrial fibrillation, and there's a fast conducting accessory pathway. Adenosine in an antidromic tachycardia may precipitate fatal ventricular fibrillation. What could be the clinical clues? Well, every time you read an ECG, you don't just read the ECG, you always will correlate with the clinical background, and that helps in the better analysis of the ECG. So there are certain clues when you are looking at the wide QRS tachycardia. If the patient had a history of a coronary artery disease, if the underlying heart is abnormal on the basis of echocardiogram, it is likely that the wide QRS tachycardia is a ischemic origin or a structural heart disease and ventricular tachycardia. Clinically, some of the signs like Canon A waves, the S1 sound varying in intensity, could all be considered as the clues for the ventricular tachycardia. Hemodynamically unstable is not necessary. That is not SVT with aberrancy, but whenever you think it is hemodynamically unstable, let's not waste time in analyzing that tachycardia, what it could be. And I think it is better to go ahead and treat as a ventricular tachycardia. The opposite to that, if you have a wide QRS tachycardia and if a patient is quite young, no other symptoms at all, that wide QRS tachycardia could be likely be supraventricular tachycardia with aberrancy. Absence of a coronary artery disease, structural heart disease could also be the clues. If the wide QRS tachycardia, the morphology during the tachycardia is exactly similar to that QRS complex during sinus rhythm, that is then most likely is a SVT with aberrancy. If you have had a history that there was a palpitations and he had gone to the clinic and it was terminated by adenosine and or a carotid sinus massage, then most likely this time this tachycardia appeared has probably become aberrant, and that is why wide QRS and most likely SVT with aberrancy. If a patient has a documented narrow QRS tachycardia once, and now he has come with the wide QRS tachycardia, well, it's almost always a supraventricular tachycardia aberrancy in the latter situation. It is very unlikely that a wide QRS tachycardia with a structural heart disease or ischemic heart disease going on and on and on for more than 5 years, and then still it is a VT, is very unlikely. Just the prognosis itself is a clue that the wide QRS tachycardia is SVT with aberrancy. Let's quickly go through some of the cases. For example, you are dealing with a case. Look at the rapidity with which this is going on. One look at it, I think it is really mind-boggling. What is this going on? Patient is not stable. Why you waste your time here? With such rapid rate, you are really not able to differentiate what kind of a complexes these are. I think it is very sane to consider this as ventricular tachycardia and treat it. For example, this case, I think is quite slow, must be stable. You have time here. And then one look, all those features we discussed regarding the ventricular tachycardia are here. Number one quick look at this, you have this as a negative concordance. And you see some of the complexes here, there is a notch, and there's a complex here which is not, there may be a VA dissociation, very diagnostic of ventricular tachycardia. Look at there are any other clues. For example, look at the AVR, it's completely positive, and then it has to be ventricular tachycardia. Let's take this one again, this possibly a ventricular tachycardia. Look at it. Why? Because this is now positively concordant, and even though there is a AVR is negative here, look at the notches along the QS pattern of the AVR. They are suggestive of ventricular tachycardia. This one, well, it is relatively, I mean, it's not very wide, but you see certain complexes amidst these kind of ventricular. For example, here it is narrow. This one is little wider than this narrow complexes. This is typically narrow. So if you have a wide QRS tachycardia and there are interspersed narrower QRS complexes, I think they help us in making the definitive diagnosis of ventricular tachycardia, because these narrower complexes define those complexes as to be the fusion or the capture beats. This one, for example, if you take this is a wide QRS tachycardia, all right, not really very wide. Look at the complexes, it looks like a monophasic. Come down to the C2, well, you have an unusual pattern, which could be called as a pattern break, characteristic of ventricular tachycardia originating from a particular place. Now, the thing is, you got to be sure that the precordial leads are not misplaced. If the second time when you take the ECG with an appropriate positioning of the electrodes and this pattern break still emerges, you are very sure that this is a ventricular tachycardia. Look at again AVR. Look at the kind of notches coming up in the QS pattern. Even though it is negative, it is helpful to make this as a case of ventricular tachycardia. Look more carefully. You know, you may get some complexes like this here, which are dissociated from the QRS complexes, and that also becomes diagnostic of ventricular tachycardia. This one, yeah, this is relatively narrow. Look at the negative complexes here in AVR, quite sharp downward, short upward complexes. V1 quite wide, but it's like trifascicular. And if we recollect, this is a RSR pattern. And in V5, V6, we have a tall R and a very small S. Even though it is wide, now this becomes characteristic of SVT with aberrancy. How about this tachycardia? This appears to be a left bundle branch block tachycardia. And left bundle branch, then you look at the R waves, the S waves, the notches, they are not there, very clean here. And look at the V5, V6 in the LBBB pattern, there is no Q here. And then leftward axis, there's this concordant axis, left bundle branch block and a leftward axis. They all seem to be suggestive of a wide QRS tachycardia with a typical left bundle branch block and a left axis deviation. And if you are lucky, if you also have a sinus rhythm ECG, for example, here, this is exactly similar to the tachycardia. The QRS morphology during sinus rhythm is exactly similar to that during the wide QRS tachycardia. And hence, it's almost certain that this wide QRS tachycardia is supraventricular tachycardia with aberrancy. How about this? V1, you have a positive R, like a RBBB, but it's monophasic. That means most likely it's a ventricular tachycardia. Come down to V5 and a V6. Typically, it is QS pattern. In RBBB, if you have a QS pattern in V5, V6, this is almost the diagnostic of a ventricular tachycardia. Go to AVR. In the AVR, you have a monophasic R. And then if you really look at the axis, it is like northwest axis. You have AVR positive. It's a monophasic V1R, V6. Then how can this be SVT? Well, we discussed there are limitations, there are exceptions. And if you have the opportunity to see what was the rhythm during the sinus, and then if you get this, for example, sinus rhythm, PR prolonged, and the QRS exactly similar to that is during the tachycardia, well, it could be most likely supraventricular tachycardia with an aberrancy. Very, very rarely, it could be bundle branch reentrant tachycardia. But then if you have a sinus rhythm ECG, which is so very abnormal in the sense that the conduction system in this patient is so much diseased that naturally, even when there is an SVT, and if it conducts down in a similar fashion, it will appear like ventricular tachycardia. So this exposes all the limitations of the criteria what we went through so far. This is another case, I think is the last case which I would like to show, relatively narrow, RSR pattern, nice. Everything is okay, so narrow complexes. But then we should remember that the ventricular tachycardia is always not very wide. This is a typical example. How do you know that this is a ventricular tachycardia even though it's really not wide? It's because you have some complexes coming up in a pentagemini form. After every 4 relatively wide QRS complexes, you are having a narrow complex here. Every 4th beat narrow, you can call it as a narrow QRS pentagemini. So if you have narrow QRSs in the relatively wide QRS complexes, well, that has to be ventricular tachycardia. And the relatively narrowness of the QRS morphology during this ventricular tachycardia suggests that the origin of this ventricular arrhythmia is nearer the conduction system. For example, this is one of those fascicular ventricular tachycardia. So this you can consider as a capture beat. And then, of course, these are the ones which are converted with verapamil most often, and the patient will be labeled as if the patient has had SVT with aberrancy. So sometimes we go on treating some of those relatively narrow or slightly wider complex ventricular tachycardia as SVT inappropriately. So with this, I would like to conclude my talk, and thank you very, very much again for the opportunity.
Thank you, Dr. Ulhas, for giving such a wonderful insight in the wide QRS tachycardia. So the question answer session we will take at the end. So next topic is sudden cardiac death current perspective by Dr. Ashish Thakur. Dr. Ashish, are you there? Dr. Ashish is son of Swat. He's from Bihar, flying flag of Bihar in the UK. So Dr. Ashish, the next topic is sudden cardiac death current perspective. Please go ahead, sir.
Well, first of all, thank you very much, and a warm good morning and good afternoon, actually, from it's cold and rainy England. So I think, and also giving me the opportunity to share with you things from an area of my special interest, and in which a lot of my work is currently focused on. So to be very precise, I think this is something which has changed, and the landscape is changing. And the next 20 minutes or 18 minutes or so, I will try and give you as much perspective as possible and stick to time, hopefully. So this is no surprise, as you might see, that we define this as death within an hour of symptoms, or there are alternative definitions of this condition called sudden cardiac arrest, or sudden cardiac death, or sudden arrhythmic death syndrome, sudden unexplained death, or unexplained sudden cardiac death. There's so many interchangeable terms, or where there's no identifiable cause post-mortem. With or without any symptoms, we will learn a little bit more. And about 25% of ST elevation MIs would present as a VF or VT, and half of them would not reach the hospital. We know that. And VF is the usual cause. And if they're lucky enough to be shocked, then they survive, maybe may not, to reach the cath lab and get something done or sorted out or thrombolized. However, survival to hospital discharge for the condition per se hasn't actually changed much over the years. And you'll see this in some of the very recent statistics, which I'm going to share. And there's so much of global variation, lack of registries, lack of reporting. And overall, it seems that the VF incidence seems to even decline with the use of appropriate medications for different conditions, especially beta blockade. And in the last year or so, you know, we're still learning, and COVID-19 seems to have changed the whole landscape pretty much a lot. So what is the average risk of sudden cardiac death for the group sitting here, you know, attendees of CARDICON 2021? Well, I mean, while you keep thinking, let me take you through this most recent publication, which is still in press, but it's available to read online. To be honest, there are no surprises coming out with this European wonderful piece of document, which kind of reiterates that still, you know, we have survival rates of out-of-hospital arrest as 8% roughly, varying up to 18%, but, you know, take it less than 10%, to be honest. And the and for the in-hospital, again, it's pretty much unchanged, with survival rates remaining less than 50% or around 15 to 30% or so, which is not different from what we know already from a lot of other resources. The incidence of sudden cardiac death, as you would see, there are some figures on the right-hand side of the screen. You can see that there is a sudden jump as somebody approaches their third decade, and there is a massive jump when somebody gets into the elderly age. And this is pretty much reflected in this paper. And you see that the blue bars start to go up from 35 years and then take a further up at 55 and then further on, a bit less in females. The 2019-20 UK outcomes from the National Cardiac Arrest Audit, which is quite strictly monitored both for out-of-hospital and in-hospital arrests, no surprises again. 9.6% survival rate for the out of hospital, and about 23.9 or 24% roughly for the in-hospital arrests to hospital discharge. So pretty much you're getting a feel that, despite whatever you might do, this is where we stand as of today. However, it might not seem as sudden, because a lot of patients will have, if you dig deep, they'll have some symptoms which you may or may not recognize, which may be missed. And they range from all sorts of expected symptoms, which could range from angina to some symptoms of pre-syncope, so on and so forth, which are listed in the slide. It seems that if you compare the incidence from the 90s until the early 2000s, there seems to be a gradual and steady decline in the incidence of this first 24-hour incident of the fatality, and people seem to have tread and crossed along that line. However, that may not be translated into cerebral organ outcomes positively and discharges. Again, coronary heart disease is a predominating cause of this sort of presentation, along with the heart muscle conditions, inherited conditions, valvular, and there are some other conditions which could lead to this, which we all know as a cardiology community. Ejection fraction has a correlation with it in terms of risk stratifying this. And let's go a little bit more into that in terms of, there's a lot of work currently being done in terms of what we know already can be translated to the cellular level, and does that really change the landscape? Yes, it does. We know there are electrophysiological mechanisms in the presence of certain substrates like a scar, a dysynchrony, mechanical disruption, stretching of the fibers or dysfunction fibers, along with ischemia, causing a lot of electrical range of electrical dysfunction, and also neurological abnormalities. And all of this could be triggered and be predisposed to by some existing genetic issues. And this is one a good paper which from 2019, give these perspectives in terms of how the risks from a population perspective to lab perspective to molecular perspective can translate into a different range of things leading to SCD, and they are just summarized on the right side of this slide, and they are self-explanatory, and you could see that it is a really pretty complex interplay of things leading into that horrible event, which would then perhaps have the potential to kill. And you can look at it in a different axis, like an axis in a completely different perspective, and put a particular patient or person at risk in terms of whichever way you wish to, in terms of having had an event before, to established structural disease, or a lot of comorbid conditions from a non-cardiac or cardiac perspective, higher age, strong family history, ST, so on and so forth. And this is a dynamic axis in which the person can flux and fluctuate as they get older, as they get more illnesses, or as the condition changes. So I think it's something which I find very interesting in my own practice. And based on this, I think there are different risk scores which have been tried, and nothing is perfect, but you can try something for your own particular patient and see where they fit in. But there are some general principles guiding these different risk algorithms, and there isn't one which fits one size which fits all, but everything is to be taken into account for one particular patient, whether that's heart muscle disease, or whether that's ejection fraction issue, or whether that's just community risk stratification, so on and so forth, or whether it's ischemic cardiomyopathy with scar. So just to give you a couple of examples. And then this is an interesting perspective where you trace the risk in in the highest risk cohorts versus the risk in the general population, and then you see that, you know, these three triangles redefine the whole thing in a completely different perspective, that the numbers would change in a triangular fashion from the base to the apex in terms of how is the incidence in the general population, how the incidence and risk in the in a high risk cohort, and how is the diagnostic complexity. So basically, the take home from this slide is that the more general we have a screening issue or a screening approach towards targeting a certain population, the less accurate and acceptable would be the complex diagnostic screening tools. So you can't just go around using an echo probe, trying door to door, looking for LVH, for example, whereas an ECG may be a much more easier method if one had to do that. So, well, currently we just rely on just a series of commonly available things to our hand, which helps us, and these are nothing new. And we know that it starts with history, clinicals, electrocardiogram, basically showing something which may be of concern to you, whether it's a Brugada pattern, whether it's an extreme amount of LVH, whether it's a lot of ectopic burden, so on and so forth, and ranging on to different forms of cardiac monitoring, imaging. MRI has a special role to play, and of course genetic testing, which may or may not be available. So again, identification of this population at risk and managing the risk, and the again, you know, competitive sports is something which has brought this to a sudden highlight in the last at least decade or so, where there is, for example, in UK, this Cardiac Risk and Young's Cry is one of the biggest charities in the world, which runs weekly clinics all along the country, and any cardiologist, any medical professional who is familiar can get trained and do those clinics in your area to try and screen the population. If someone's concerned, there's a lot of programs going on in schools, so on and so forth. So I think it's something which one has to really think about how we want to approach. Imaging is key, of course, to demonstrate a scar, to demonstrate abnormalities, which would, of course, make you feel that this person is at risk and we need to do something else, something more, whether it's monitoring, whether it's offering them medications, whether it's offering them device treatment. Well, that's much more tailored. One-stop clinics, again, this is what I was referring to, called Inherited Cardiac Conditions Clinic. We generally have one in every region, which is a one-stop clinic. You have a clinical appointment, an imaging appointment, and at the same time, the family counseling, and if with or without a genetic blood test for the whole family. So that's generally offered as a one-stop service. And this is the model we are moving on to more and more and more going forwards in order to identify patients, especially for primary prevention treatment. And that's just a complex slide, which was published last year in the American Heart Association about the genetic sequencing, how it's evolving and changing the landscape further. Inherited conditions, I think I've already said that. There was a good paper by ESC, which you can refer to for more information. A lot of genetics in the QT side of things, which is just the tip of the iceberg, where most are undiagnosed. However, the ones who come to light are taken care of properly if they're in the right system. I wouldn't go into details of this. You all will be fully aware of the standard indications for primary and secondary prevention, ICD, with or without cardiac resynchronization treatment for the high-risk population or survivors. So rather than spending time on this particular treatment, which again, this is not the scope of this talk, but there are newer treatments becoming available, for example, subcutaneous ICD, just to name a few. I'll spend the last 3 minutes, I can see the timer very well, on talking about a couple of things. So COVID-19, the last 12 months have been, or 15 months to be honest, or 18 months have been a complete nightmare in terms of this managing the cardiac arrest scenario. And there's been a total confusion on research guidelines, what to do, especially with bystander or even in hospitals, so on and so forth. And of course, the awareness is going up. There was a time when people did not want to offer bystander CPR, and the calls for help kept on going, so on and so forth. The standard guidance still remains the same, that you call for help, start with compression, 5 to 6 centimeters, 2 to 2.5 inches, aiming for 100 to 120 beats per minute. And if possible, unless you're suspecting COVID, give 2 rescue breaths at every 30 compressions. And if you're suspecting COVID, then compress only in terms of chest compression, and loosely cover the face with a cloth, not tight, not block. That's it. It's pretty much, but that changes for in-hospital conditions as per the patient risk, with or without, with the right level of PPE for category 2, 3, etc. Going forwards, it's going to be electronic, and this slide nicely summarizes that very well. What's the future of management of this? And I'd like to spend the last minute or so as to what COVID-19 has actually done to this. So there are a couple of papers listed here. The first one is an opinion from Indian Heart Journal from September last year, which said COVID-19 could be a risk factor for sudden cardiac death. This is the first series in the world which actually put papers and everything together, studying 1,000 cases of in-hospital and 2,000 cases of out-of-hospital cardiac arrest, and studying them before and after the pandemic from January 2020 to July 2020. And this was a summary paper on COVID-19 and arrhythmias. The take home was that, of course, cardiac arrest does happen with COVID. And this is my last slide. I'd like to spend a few minutes. You can read through that, there is a good incidence. It's multifactorial. There's direct correlation between systemic illness severity and the incidence of sudden cardiac arrest, or, well, the S is only if it happens in 24 hours. And the death risk is more than doubled, especially in women who have much higher incidence. And the survival rates are much lower than expected for the patients at 30 days. And no patient, until these papers were published, had left the hospital. So that is the take-home message. And the bystander compression CPR may not be effective because it's a respiratory illness. So that would explain why this would fail in those patients, and ECG monitoring remains the key. Thank you very much for your attention.
Thank you, Dr. Ashish, for giving such a nice talk on this important topic, the sudden cardiac death. So, Dr. D.P. Khetan, would you like to add something in this regarding to all this stuff? Sir, unmute your mic, sir. Khetan, sir, unmute your mic.
I have unmuted my mic. In addition to the first sentences, whenever the mind accepts, there is a sequential progression from the atria to the ventricle through his Purkinje system, and the ECG confirms it. It is just like the case of the supraventricular one. Whenever, due to the slow conduction through the muscles, if you get confirmed by your mind by any means of that thing, whether by seeing the AVR lead or something else, it is the case of the ventricular VT. Of course, all the things have been very well described by the speaker. One thing I want to say that whenever one sees the altered or displaced ventricular lead like the V2, just the space lead like that. One should think in terms of the subepicardial VT, which gives rise to the V2 positive in the lead, R positive in the V2 lead. Otherwise, it is the R2 negative in the S negative in the V2 lead. Otherwise, the positive leads. So these things indicates the subepicardial origin of the VT nearby the great cardiac vein. With these words, Dr. Ashish Thakur has spoken very well. I don't want to add anything. Rather, I have learned so many things from him. Thank you, sir.
Can you tell us, sometimes there is very difficult to differentiate between SVT or VT. So in those conditions, EP study can help on that count, how we can do that. Dr. Ulhas, please unmute yourself.
Yeah, it is not, it's not very essential that, every wide QRS tachycardia where you are confused, you need to be doing a EP study, because EP study is an invasive study. So you will have to work hard on finding out whether this truly is appearing to be a ventricular tachycardia on the basis of the clinical clues, echocardiogram, and the history, etc. If you suspect that it must be like a ventricular tachycardia, well, then in that case, you may go for a EP study. If you think the prognosis of that wide QRS tachycardia is good, clinical syndrome is quite benign, maybe you do not really require, you may actually think that, you could treat the patient with some medications and go on, and maybe you give a chance for a recurrence once on that medication, and you are not sure what is the tachycardia, you thought it's a benign, you started medicine, on top of the medications, he develops again a symptom. I think it makes sense to send for an EP study. So it's a clinical decision, not necessarily to distinguish whether it's a VT or a SVT.
There is one question from Ashish Thakur. Just I want to know, after about a sudden cardiac death, patient came out from the sudden cardiac death. So what are the next approach? How will prevent the future cardiovascular events? Which drug is very much important, in which we will try the base, especially in patient of non-coronary setup and got a sudden cardiac death. In a good coronary setup, there is no problem. A guideline is, but in non-coronary setup and patient got about a sudden cardiac death, and there is no reversible factor like hypokalemia and other things. How will you manage?
Yeah, so I mean, it's a very, very important question, and thank you for asking it. I think the key thing here is to approach secondary prevention. If there's no identifiable cause as such, especially coronary artery disease, cardiac muscle disease, you can then go and look for other things. At the same time, the first thing you want to do is to consider this person for a implantable cardioverter defibrillator, and you'd only start to do anything else after that. You would not delay the secondary prevention treatment. In terms of medication, where it stands, one of the key things is offering a beta blocker, and that's something which I would recommend at the earliest. Again, if this patient is with you in the hospital, can afford from an economical perspective, then they should get a defib straight away. If they're resting brady, for example, they may not be able to tolerate any medication, rate limiting especially. So that will help you with that side of things as well. So that's the short and sweet answer. And if there's any element of LV dysfunction, I mean, ideally you want to subject them to cardiac MRI to look for anything in particular, any abnormal signal intensities, anything at all, any simple finding. And if that is also normal, which is not unexpectedly, you might put them in an implantable loop recorder, but then mind you, they've survived an event like that. So the ICD will do the job. all in one. So that is the key here. If that's along with a degree of beta blocker as much as tolerated. So if that answers the query. Thank you.
Dr. V.K. Sukla, are you there? Do you want to add something? Dr. V.K. Sukla? So he's not here.
No, sir.
So
I have a question to Dr. Ashish Thakur. I have a question to Dr. Ashish Thakur.
please go ahead, sir.
Good afternoon, Dr. Ashish Thakur. Almost you have covered all the area of the sudden cardiac arrest. But as a clinician, I just want to know from you, seated at Bihar, having no such data of a sudden cardiac arrest minus coronary artery disease. So we come across at situations where we find that the patient has come with the tragedy of the sudden cardiac arrest and the patient was not having any coronary artery disease. So what suggestion you give us for the preventive measure to a clinician seated at Bihar? So ECG sometimes do not give a much more idea. So what do you suggest?
So the first of all, I mean, I work on both sides of the continent, so it is not it's not a new or naive thing for me. If I came across a situation like this, first of all, I'd like to confirm the diagnosis. That was it a true sudden cardiac or aborted, to be honest, it's called an aborted SCA event, which the person survived. What is the evidence? What is the history? You'd like to know as much as possible about the history and the actual event, unless it's happened in the hospital, because there will be subtle markers in terms of, and if you're confirmed and if you're happy that this is actually what have happened, or you're not sure on balance of probability, you think the person would have had a cardiac syncope, from which they came out, well, then you really need to take it seriously. And alongside the workup, which would start with an extended monitor, imaging, and all those things, you would want to really look at from a holistic perspective. And again, history there comes as key. In terms of preventive aspects, I think in terms of prevention, well, along with the usual lifestyle measures, which I wouldn't go into, I think you would like to, first of all, offer them medical management, which are proven to suppress arrhythmogenic activity in the myocardium. And they could range from offering them a beta blocker to amiodarone, or whatever they can tolerate, whatever is in hand. It all depends on the actual case scenario.
I wanted to know from you about the preventive strategy to diagnose. We are taking care of the high-risk patient for the prevention of the. So we want a strategy. So what strategy we should apply to correctly diagnose that this patient might not enter into a sudden cardiac death? So
I think with the, if you go back to the slide which showed that and that the incidence of sudden cardiac or cardiac arrest itself is about 1 in 100,000, less than 35 years of age, and it goes up to about 1 in 1,000 or so when you exceed 35 years. That doesn't simply call for a population screening strategy. No. So what you would want to have is a targeted strategy where you might come across high risk populations, because I don't think there is any population strategy in place. Yes, you can target people, for example, somebody who are athletes, who are into extreme or endurance training, who are into certain degrees of employment which involves themselves and people at risk, airline pilots, so on and so forth. So I think that's a broad answer, rather than having a sudden or a VF screening strategy. Like we don't screen.
Excellent explanation.
One question, sir.
There are 2 questions in chat box for Dr. Ulhas.
So
there are 2 questions for Dr. Ulhas.
Can I finish my answer, please? Can I finish my answer?
Yeah,
I think a good way to look at it, that you don't try and keep you don't go out and look for atrial fibrillation in the population, which is the commonest arrhythmia above a certain age. So if that's what perhaps which can have a big impact on health care and health settings, causing a stroke. So I think if you look out for certain degrees where this is much more commoner than general population, yes, you can then have targeted screening like we do in different places. Even in Hridayam Foundation, we have a huge subset. We never realized that there is such a hidden number of patients with hypertrophic cardiomyopathy. Just to give you a small example, and there is indeed that the iceberg, of people who are high risk by definition, and they are the ones who need to be identified. And there has to be a proactive register. And let's say in a private practice setting, we all need to have our own registers of, okay, well, we've seen over the month, we've seen 35 or 40 patients with a range of conditions, and they all could have more arrhythmic risk, if not SCV itself. And that arrhythmia need not be VT, VF, that could be simply AF or high burden of ectopics, high burden of facial ectopics, high burden of VEs, so on and so forth. So I think that would be my approach in a setting like Bihar, where I would do the same, in my foundation work. Thank you.
Thank you. Thank you very much.
Thank you, Dr. Ashish. Thank you, Dr. Ashish. One question from Dr. Ulhas. We are passing through COVID era. So why there is increased sudden death in COVID patients? Is it asystole or ventricular tachycardia? The other question is, what is your favorite antiarrhythmic other than amiodarone? What drug you would like to use in arrhythmia, particularly ventricular arrhythmia? Please, sir, unmute yourself, sir, Dr. Ulhas.
Yeah, so if your practice is amiodarone for the ventricular tachycardia as the first drug of choice, I don't think there is much debate about that, but some people may not really appreciate that. But let's consider amiodarone is a favorite drug to begin with ventricular tachycardia. I think there are 3 more drugs have been found to be quite useful in ventricular tachycardia, especially when there is a structural heart disease or ischemic etiology. And you have a sotalol now available widely. You have mexiletine, which is quite widely available these days in the country. That's a good sign. And then, as we were discussing, if the ventricular tachycardia is in an idiopathic context, it's actually a normal heart. Of course, the drugs of choices are calcium channel blockers and maybe even beta blockers. So that's how you're picking up your drugs.
Thank you, sir. We are running short of time, so we will go for we should conclude this session of arrhythmia, and we will go for another session, the coronary RTD session.
Yeah, I think I need to come in for one last comment made on Dr. Ketan's question. That what is the commonest form of sudden cardiac or the well, you've seen the slide, the largest data set available for both outpatient and inpatient cardiac arrests, and it was non-shockable rhythm, not the shockable rhythm. Thank you.